Okay, thanks very much for that. And I'd also like to acknowledge we're meeting on the lands of the Wurundjeri people of the Kulin Nation and pay my respects to elders past and present. And also, there's a really good movie that we all must see this Sunday on ABC. No, I don't work for the ABC, but The Australian Dream. It's a story of Adam Goodes. I actually took my kids to see it when it was on at the cinemas, and a really brilliantly made film about the kind of institutional racism that we experience in this country, full stop. And as health providers, it's not until we address that are we going to address the huge disparity in Aboriginal and Torres Strait Islander health. So I really encourage you to see it with anyone, including your kids, 8:30 this Sunday. So I've written a 30-minute presentation that I'm going to try to squeeze into 20 minutes. So I'm going to talk quite quickly. I thought I was speaking for 20. It's totally my fault. So I apologise in advance for some of the slides. And the font came out a bit strangely. So I want to talk about what we're up to, what's on the boil at the moment. The question that I've been asked to address here is channeling data. So I'm going to focus on what data to channel and where to, and to provide some examples of work that we're progressing with SCV and our other partners, including health services and clinicians, to I guess see greater utilisation of data. And also talk very briefly about what we have planned in 2020. So we were developed and launched at the same time as SCV, but we took a bit longer to get started. So we've been going for around 2.5 years. Our aim there, our mission is to deliver trusted information to inform better decisions that improve the health and well-being. We see health much broader than just around physical and emotional health, to a broader definition of health. And our partners and stakeholders are service providers, organisations, clinicians, community and government. Our approach to data, so we have access to the full 1,200 data sets within DHHS and beyond. We also work closely with the Victorian Centre for Data Linkage, which is an accredited linkage agency who is enabled to link not only data outside of health within Victoria, but also federal government data, and that we're really keen to work through that. We currently access a range of administrative data, patient-reported, clinical data, health service and population health, and that does include clinical quality registry data that I'll talk about very shortly. That's quite new. We've only been accessing those data in the last 3 or 4 months. The whole intent of our product is to improve clinical practice, improve customer activation, to assess disease burden policy formulation, and also to assist the government and others in relative resource allocation. If we can understand where care is most needed and how we should prioritise that, then we play a role in assisting that. For those of you who may not have come across some of the VAHI reports, we essentially deliver five main reports, although this, based on the recent challenges experienced by Victorian government and health services, we're probably going to be moving in addition more into looking at financial sustainability and value, including looking at low value care over the next 12 to 24 months as well. So this is what we're working on at the moment. 5 main reports, 1,500 PDF reports per year. We're moving to an interactive database. We'll see this change from PDFs into interactive, which is the sort of information that you're needing at the coalface. So Inspire report for clinicians, board safety and quality. We're the only state to actually deliver a board quality and safety report specifically for boards. Comparative data there. Monitor, which really speaks to the funding operations and the SOPs of the health services. Prism, which is kind of this behemoth of a report that we dump a whole bunch of shadow metrics and other metrics into for clinical and other uses. And the VHSP, the public website that the Minister uses to provide information largely on utilities, so waiting lists and so on, to consumers. And that's the VHSP there. We also have a range of epidemiologists working within VAHI, brilliant epidemiologists that provide what I believe to be the strongest population health reporting unit in the country. we also do a range of bespoke reports, including, as I'll talk about soon, a big link data report. We're the only jurisdiction to release that report. You might have heard me talk about it in previous conferences, but that's the sort of work we do, and these are the sort of population health reports that we work on. One thing we are looking at doing over the next year or two is to get identified population level survey reports so that we can link data on behaviours, opinions, views within the community to acute data, so that we can start to really understand the social determinants of health, why people are sick in particular areas and why people are more healthy. We currently can't do that. They can in Canada, where they have identified population health survey data. There's no state, I understand, doing that at the moment, so we're just exploring that with the inclusion of a question in this year's population health report, asking what people think of providing those data, of that information. Just in the time we've been established, we have a number of Australian firsts. The first regular private hospitals quality and safety report, we're the only state to do so. We've delivered 3 of those now. The first big linked data report I'll talk about very shortly. We are linking clinical quality registry data. We have 5 CQRs that we will be linking with at least acute care data and hopefully more. Board safety and quality. To the general practitioner in the back, we're also the only state to look at scoping the linkage, the acquisition and linkage of general practice data, those data being symptom and diagnosis at the GP level with acute care data, so that we can start to really look at impacts on the system together as a whole health system. How can we actually work between general practice and acute care at a system level to reduce admissions, readmissions at the coalface? We don't have that data lineage, and it's absolutely bizarre that we don't. You speak with transport and police, full access to data, yet we're totally blind on general practice data, apart from the Beach study, which was closed off years ago, and a few others. So this really is quite an exciting opportunity if we're going to impact on admissions and readmissions to hospitals. That's where we really need to start looking. And we're about to launch the interactive data portal as well to health services and clinicians. This is I've blacked out the health service that this relates to. We actually launched this on the 9th of December to 120 pilot participants, and also launched it last week to every public health CEO. So every public hospital in Victoria now has access to this portal. This is just one of the dashboards on emergency care. This is all the comparative data for every public hospital within Victoria on time to treat over minutes. You'll see the different levels there. You can actually, the enhanced value in this interactive portal, you can, with the right rights, you can click down to unit level. So you can see which patients are the outliers here. You can access trend data and comparative data that you weren't able to access before. We'll be starting small and scaling up these data. We have already included some linked data in this, particularly the measure around readmission to any hospital requires linkage. So stay tuned. We're officially launching that in April. So hopefully do away with those 1,500 PDF reports that we produce each year. Ultimately do away with them. So when we talk about channeling data and what sort of information do we need to be asking, well, what do we actually need to improve? And this was some really good work undertaken by the Australian Institute of Health and Welfare a few years back now, but it places Australia on a continuum with a range of challenges that we have at a system level across primary care, acute care, cancer, patient safety and experience, and it's a bit all over the place. So these challenges do keep changing as well, but we're not the top of the list or bottom of the list. We're kind of middling at best. Many of those patient safety indicators that we do collect at the OECD level, though, are poorer, unfortunately. Many of the population health indicators are better, and that's why we have a quality of life and life length is longer. But we do need to ask the question, well, what are we using this information for? And one of the things that we're really cognizant of and working toward at VAHI is working closely with those who actually use the information. We're not just collecting data for data's sake. If there's a measure that we're spending time and money collecting, I want to know how it's being used, and if it's not being used, we should get rid of it. And also recognising that information and data and reports fill only one part of a quality improvement system. There's a whole range of different activities that are evidence-based to go to quality improvement that SCV and others, you in your daily lives work toward. This is probably the best report I've seen in sort of attempting to collate all of those quality improvement strategies, and really places the role of data within some of those strategies as well. It'd be great to have a similar Australian type review that kind of starts to articulate those sort of quality improvement strategies. But as you can see, within them, information and data does form a critical part of it. But just to reiterate that it has to be part of a system. I've got patient experience data going back 10 years, and Louise would know this, it's just flatlined. Why is it flatlined? No one's actually paid attention to it. When you paid attention to it, you see it's still flatlined because we don't have an improvement strategy. So this all has to be coupled with improvement strategies, and that's the difficult part. We can only be as good as the improvement strategies that see those metrics improve. But I guess the point of this slide is to really embed the role of data and information within the quality improvement system. The change is the hard part. I did want to talk about hacks. Now, Stephen promised me he wasn't going to talk about hacks when I came in, and he did, which he mentioned. But I think this is a really important part, and we are going to be focusing on this more this year. We're one of the few states that do report hospital-acquired complications at the board level. Very few states actually do. As you're probably aware, the Commonwealth is starting to dock the pay of the states for increases in hacks. So this will only, the focus on this will only increase. So I sit around the kitchen table with my kids and tell them fun facts from data, and they appreciate that. But some fun facts about hacks: 12% of admitted patients suffers a complication, increases to a quarter if the patient stays overnight. Pretty profound. The cost to Australia is $4 billion per annum. That's 15% of total healthcare costs. So this is huge. The interesting thing, and this is partly from Stephen's work actually, as well as the Commission, the risk of complication in one specialty is only weakly associated with the risk of another specialty in the same hospital. So it's not like a virus, and it's kind of patchy. The risk of complication varies within as well as among. So it's a bit all over the place, simply very much focused on what happens within the unit and possibly down to the surgeon or health service level. These are the major hack groups. That's from the Commission's website. Really brilliant report they've got, and I encourage you to go and see that. It's on the State of Patient Safety and Quality in Australia, released last year, that has quite a deep dive into hacks. We have the data for all hacks in Victoria, a really strong program using ChatX, which is obviously all the hacks combined, 144, whatever it is. The hacks are just a component of those. We've calculated the costs. We are getting better. They are reducing. But you can see they're the costs over in the far right for Victoria only. So this is huge. We are doing better though, but we can always get better. Again, this is Stephen's work, and he kind of showed this slide on this graph on the right-hand side. There are incentives for reducing, similar to sentinel events. We haven't instituted them in Victoria. We're just kind of shadowing them. Modelling has shown that the hospitals have incentive to record all the complications because you get funded. But what Grattan has shown is that the cost of complications is 3 times larger. So not only should we be really focusing on this, because it's harming patients, it's not good for their health and not good for quality and safety, but it's costing hospitals 3 times more. So this is a great opportunity to address something that is totally preventable, and actually looking at the data from the private health system that as we do access, there is a huge difference between hacks and private versus public hospitals. And even if we lifted the best 10% of public hospitals, that's 250,000 patients without complications per year. How can we learn from those hospitals that are doing well is the question. And there are strategies under each of those hacks that can improve care. These are some data from the ChatX system that we run at VAHI. Now, ChatX is it's almost using live data that we use. We get it down to a hospital level. I don't think David Plunkett from Boxer will mind me. I haven't asked him, but I hope he doesn't mind me showing this graph. But this is ChatX. This is a hack for hip replacement. They're currently sitting exactly on average of all hospitals. There was a time when they were about 3 or 4 times higher. what we're able to do through this ChatX improvement system. So they were sitting at around 10%. Implemented an improvement strategy, a deliberate and intense improvement strategy, saw it level out over those 3 to 4 quarters. So using these sort of ChatX data, and these are available to all services in Victoria, and we're coupling this over the next year with work with SCV for improvement. We can see reductions in hacks, but they need to be deliberate programs to address them. I did want to talk very briefly about the National Data Linkage Demonstration Project, but I'm not going to, only to say that we are the first jurisdiction. We want to see more of this. The linkage agency that we have here in Victoria, the Centre for Victorian Data Linkage, have the same privacy and security rights as the AIHW. We're really keen, and I don't know if Sally, you're able to influence this, we're really keen to access the complete records, PBS and MBS, so that we can see the head to tail picture of patient's journey, because that's the bit that's missing. We're not too sure why we can't access those data. We provide acute care data to the Commonwealth, but we're not yet receiving those data on MBS and PBS back. Really critical, because I believe that those PBS data that we've seen in this big data report provide a goldmine of information on pharmacovigilance, post-market surveillance and so on, that we haven't really mined at all. We found through this that the rates of prescribing OACs and is about 3 times higher than the best estimate we had before. We couldn't have done that without these big data, but we're not getting them. So we really need to work better as jurisdictions and the Commonwealth to access that full data set so that we could start to uncover these issues within the health system. We did that with New South Wales. I won't go into it. That was the news headline, which you can expect. Hospitals are to blame, of course, but I do think we need to, as Sentinel Events headlines kind of seem to taper off, we do need to start publishing them. Also, I did want to talk very briefly about patient-reported outcomes, but more specifically about experience data and the VES data that we have. We look at our patient experience data. We are refining that this year. We're making it electronic, digital only, moving to fewer questions and so on. There's some really strong evidence around the association between outcomes of care, patient outcomes, and their experience in care. So great work by Kemp in 2017. I think could have been written in MGAA, I'm not sure. Patients who indicated they were not involved in care decisions, 34% likely to be readmitted. Those who didn't receive information, 25% more likely to be readmitted. And those who weren't involved in care and didn't receive written information, 50% more likely to be readmitted to hospital. So pay attention to the patient experience data, because it is really critical to the care and outcomes that those patients experience. And we can prove that through linked data as well. So that's the message there. Public release of data. I'm a kind of supporter of more public transparency than less. The best evidence I've seen has been in Wisconsin, where a researcher there, Judith Hibbard, took 100 hospitals in that state. They all agreed on 12 metrics for quality and safety. They said, okay, we're not going to do public reporting for you over 2 years. In fact, you're not going to get any data on these 12 metrics for 2 years. This third of the group are going to get a report privately. We're not going to give it to any consumers. And the last group, everything's naked on the beach, as we call it. Everyone's there together. Everyone sees everyone's data. The public see your data. This is the pre-post of that, using those 12 metrics that all those hospitals used. With the public report, significant improvement in over 30%, decline in less than 2%. Greatest impact was in public reporting of those quality and safety data. Private report had a slight improvement just when you're giving those information just to hospitals. No report, no difference. No difference at all. In fact, she did some further research that showed that the poor performing hospitals, they actually, their performance improved the greatest in that for public reporting. So there is a lot of evidence developing on public reporting. The change mechanism isn't around patient selection. They don't look at these data. In fact, we know that only 3% of patients on average look at anything about the hospital they're about to go into. They do more research on buying their fridge than they do in looking at hospitals. They don't look at that. This is all about, I guess, what I call professional shame. No one wants to be bottom of the list. you don't want to be in the hospital at the bottom of the list of the quality and safety data, and that seems to be the change mechanism here. Just finally on CQRs, we're about to link data from the intensive care, the ANZICS clinical quality register with acute care data, which is really exciting. We also have 4 other registries that we're about to link as well. Those linked data will form part of the board safety and quality reporting, as well as probably the monitor report over the next year or so. Really useful information. I'm a huge supporter of registries. If only there was more federal and state government funding for them to support their sustainability would be great. Our priorities, we're going to increase our scope beyond healthcare to look at the full continuum. The interactive portal again in April. We are going to be focusing more on hacks on low value care this year, exploring linkage with primary healthcare data and also reforming some of the patient care and CQR work.